Hi, this is Brad, and this is my submission for the peer competency case study. I'm going to share my screen here. So my hypotheses regarding the potential conditions, my primary hypothesis is that this patient has a cervical spondylosis, and the displacement of the cervical vertebral body might be causing some neck pain, and then possibly compressing a nerve root leading to the radicular symptoms. And some things I used to come up with that hypothesis is under the initial examination findings, P1 is reproduced with right cervical side bending, and then also some of the symptoms are reproduced with cervical flexion and extension. Some other conditions that I thought could lead to the problems are osteoarthritis, which he was diagnosed with 12 years ago. Might also be causing some nerve root irritation. Osteoporosis. There was nothing in his medical history that suggested osteoporosis, but possibly the limited cervical lordosis and thoracic kyphosis could be the result of compression on the anterior vertebral bodies. So that might be contributing to the pain. And then these were some other ones that I thought were less likely, but just considered and jotted down some ideas. So compression on the nervous system just farther down, like the brachial plexus or the median nerve, which I just thought because of him dropping the tools, the median nerve might be affected, but less likely since the symptoms go from the neck down through the arm. Neural tension, could be some tension along the nervous system, which could be tested with the neural tension test. But again, I thought it was less likely because his symptoms are in the right arm. And when he does cervical side bending to the right, the pain is reproduced, which if there was neural tension, it'd be more likely that the pain's reproduced if he side bends to the left. So I thought that wasn't very likely. And then I did not see any red flags that indicated malignancy or fracture. Contractile issues with contractile tissue could be ruled out because pain was reproduced with active and passive range of motion, which it wouldn't really be, I don't think it'd be produced too much with passive range of motion since the muscles aren't shortening. So then on to the additional examination, medical screening. I want to measure blood pressure because he has a history of hypertension. I would want to do an upper quarter neuro screen, including testing dermatomes, myotomes, DTRs, possibly narrow it down to a specific cervical level. I would want to do an upper motor neuron screen to see if there's any upper motor neuron lesions in the cervical spinal cord. I want to get a better idea of his pain quality, even though it says it's radicular. I would just want some more descriptors for that. And then I would do more in-depth thoracic spine screening, which they did PAs, but I would also want to test side bending, rotation, flexion, extension, just do a more comprehensive screen, because something in the thoracic spine could be causing problems somewhere farther up the chain. I would want to get more information about his osteoarthritis, which he was diagnosed with, such as where it is, because it could be in the cervical spine. And then I would want to get an idea of when he had his last imaging done, possibly send him in for some more imaging if it has been a while since he went in, which might also give me a better indication on his bone, which could give him some more information about his bone density if he did have osteoporosis. And then I want to get some more information on his asthma, if he's managing it well with COVID, Could also do a COVID screen if wherever I'm working has precautions about COVID. Um, I do think this patient belongs in physical therapy. Um, I did not see any concerning features. Again, I didn't see any red flags for malignancy or spinal fracture. So we could begin a trial of therapy. And then going back to his osteoarthritis, osteoporosis, possibly order some imaging if it hasn't been done in a while. According to the SIN model, I would classify him as low severity because his symptoms don't seem to be limiting him with his functional or occupational tasks. It takes a while for, I think it said, he gets increased pain following long duration tasks or activities. So it takes a while for his symptoms to come on. Irritability status, according to the tissue resistance classification, I would put it as subacute. And that's just going off of the inability to provide overpressures due to pain. I took that as they could get to end range. He felt pain there, and then they couldn't provide overpressure after that, which would match with the subacute irritability. According to the functional classification, I would put it more chronic because he can do long duration tasks, and symptoms only increase after he does those long duration tasks. And then as far as the nature, I would put it both in the mechanical and neurological category. Because the symptoms are radicular, that indicates more of a neurologic mechanism. However, the motions with cervical range of motion, mostly side bending, turns those symptoms off and on. So it's reproduced with movement. Finally, if we take my primary hypothesis that the displacement of the cervical vertebral body is causing compression on that nerve, I think this patient has a good prognosis for physical therapy, which could help reduce his pain symptoms and increase his range of motion. If you want to look up this is an article I found that that provides support that physical therapy is effective for treating cervical radiculopathy from spondylosis. To be honest, I didn't look through it in too much detail, but from what I did read, it sounded like physical therapy could help this person out. So that is my peer competency neuro case study. Thanks.